Well, I started my professional life as a mission doctor in Ghana for 5 years, and very soon I was in charge of the medicine supply system of the hospital and later of the whole mission sector in the country. And we did not stock insulin, it was too expensive. I remember simply that we said we had a little bit of it for inpatients, and the idea that outpatients would come every month, and it was simply not possible for the mission hospital to afford it, and we didn't buy. You can say that was 30 years ago, but I remember that quite clearly. So starting with that, with the human face, now I'll end with it, but in the meantime, when I look at the markets, then you can see there's two reasons why there's actually not enough competition. The suppliers are very much concentrated. We talk about 3 big suppliers with 99% of the market, or 95%. And we have a very scattered, fragmented buyers market. Basically, many people are on their own, countries are on their own. So that's 2 reasons why competition doesn't work. And in the meantime, we see a strong pressure to newer products, marketing, newer products which do not necessarily give much additional advantage. And it would be okay if you had enough money. But if buying one type of insulin at the price that you could also pay, say, treatments for 10 other patients, then it's not wise. So is that a market failure? You could say that, well, this is the market. Well, other people say the market is always right. So probably it's not a market failure. And I think it's a public policy failure to rely on the markets to solve this problem. And that's why my conclusion is that we need strong public policy interventions for this sort of thing. So what would it be? And I agree very much with the strong link with universal health coverage. That will give at least strong buyers, probably more treatment guidelines and a way to design a basic package that includes the necessary care, including insulin. So good selection and really focusing on those medicines that offer the best value for money. And then better prices, more competition, price information, taxes, good quality, new generic manufacturers or new biosimilar manufacturers. The pre-qualification is one way of doing that. So that would be basically improving the market by strengthening the buyers on behalf of all the patients. And then another thing about R&D. I note, of course, that most of the insulin products are now out of patent. There are more to come. Some of the devices are still on patent. It becomes a little bit like a printer. The printer is cheap, but the ink, every card is the same price as a new printer. So that may be a little bit this system we are slipping into. But we do as if there's no more research needed. I mean, it's still an injection every day. I mean, I could think of, well, it's not even heat stable. You have to put it in the fridge. So I could imagine a better product, heat stable, or an implant once every 3 months, or a tablet I mean, I still could think of thinking about therapies which would be much more convenient to the patient. Now, that's also, you can say, it is a public policy failure to rely on the market to do that. And then when it comes, it will be exorbitantly expensive for 20 years. So that's not the way. This is typically, you can say, you can identify as countries together a public health need. We need better types of treatment for diabetes, and then have public money put into it, so that when the outcome comes and you have the product, it sort of straight away becomes a generic with a big access plan where you have differential prices, etc., and you don't have to wait for monopolies, patent-based monopolies, to prevent access to many people. So that's on the R&D side. And I would like to close, coming back to the human face. I think there's also an increasing role for the consumers. And let's think about, especially to introduce some scrutiny. How are the companies actually behaving? What are their policies? What are their practices for access to essential medicines? Let's focus on low and middle income countries. Well, there is the Access to Medicine Index, which does it, and which already includes NCDs and insulin, so we have a lot of information coming from there as well. But you could also say there may be some monitoring system may be needed, an insulin access monitor or something like that, run by independent. And that brings me back, and I'll close with the human rights framework. And the human rights framework of accountability would consist of 3 things, and I think we need all 3. You need the data. You need full transparency on the data, availability, price, quality, all that. Secondly, just having the data, David, with all actually, of course it's good to have the data, but now we need an independent review of the data. We'll probably say, well, we're starting to do that. And then you need the corrective action. That's 3 more things. That together is accountability. And I would strongly think that we would need that here. So with these words I would like to close, but I would really focus on a real public policy intervention that's needed. Thank you.